Good afternoon, everyone. Today we would like to discuss the drug Salmeterol, and to do that, we will use Susan's story as an example.
This is Susan Allard, and she is 40 years old, married to her husband Pierre Allard. She is a French woman who used to live in Paris but moved to Melbourne, Australia, later in her life.
During her childhood, she developed an allergy to dust mites and was treated with antihistamine tablets called Zyrtec. Because of her allergic reaction, she developed severe asthma at the age of 8. Susan is taking Ventolin, but it is uncontrolled as she is using it every day. At the age of 20, she worked at a clothing factory for 10 years. After she got married to her husband, who is a heavy smoker, she became a passive smoker, which worsened her asthma. In her later years, she developed hypertension at the age of 32 and was prescribed captopril by her GP.
This is not a surprise considering Susan's family history, as her mother developed asthma at the age of 10 and her father had hypertension at the age of 35.
One day, Susan was going about her daily activities when she felt a shortness of breath and reduced physical activity tolerance. Her husband, Pierre, noticed this and took her to the emergency department. The doctor took an X-ray of Susan's chest area, which showed fibrotic changes consistent with undiagnosed chronic obstructive pulmonary disease. Due to this, the doctor recommended Susan to take Salmeterol at a dosage of 50 micrograms twice daily.
Salmeterol is an inhaled drug which acts locally in the lungs. It is metabolized in the liver by the CYP3A4 enzyme and excreted predominantly via feces. The drug target is a receptor called beta-2 adrenoceptor. Its action is a long-acting beta-2 agonist which causes bronchodilation. Due to Susan's history with Ventolin, it is very important to regularly assess inhaler technique and the patient's compliance with drug dosage and continuous drug usage. Her shortness of breath and exercise tolerance needs to be measured to assess efficacy of the drug. Drug interactions include beta blockers and beta-2 agonists. Beta blockers antagonize the therapeutic effect of beta-2 agonists and may precipitate asthma. Theophylline and beta-2 agonists. Theophylline can potentiate hypokalemia induced by high doses of beta-2 agonists.
Now, let's talk about the outcomes of using the drug Salmeterol. It is a selective, long-acting beta-2 adrenoceptor agonist which is prescribed to patients with asthma and other chronic obstructive pulmonary diseases. This drug has a slower onset of action but has been shown to be more effective against histamine-induced bronchoconstriction and has a longer duration of bronchodilation than the recommended doses of conventional short-acting beta-2 agonists. It produces its effect within 10 to 30 minutes, with the peak effect being between 3 to 4 hours. Salmeterol is very potent and produces long-lasting effects by inhibiting the release of mast cell mediators such as histamine, leukotrienes, and prostaglandin D2 from human lung fragments. It is known to inhibit early and late phase response to inhaled antigen, and the late phase response lasts over 30 hours after a single dose when the bronchodilator effect is no longer evident. Salmeterol acts locally on the lungs, and therefore plasma levels cannot be used to predict the therapeutic effect. Using Salmeterol leads to bronchodilation and inhibits bronchial hyperresponsiveness. It should not be used in patients whose asthma can be managed by occasional use of short-acting inhaled beta-2 agonists. Salmeterol complements the effects of oral or inhaled corticosteroids, and that's why Susan's doctor prescribed her an inhaled corticosteroid, beclomethasone dipropionate.
Some of the side effects that may be seen with the use of Salmeterol are tremor, heart palpitation, and headache. Salmeterol is suitable for long-term regular treatment of reversible airway obstruction in asthma in patients who are receiving inhaled or oral corticosteroids. As mentioned before, an interaction between Salmeterol and beta agonists can lead to hyperkalemia. This is because they act on the sodium-potassium pumps. An overstimulation of these pumps will lead to an influx of potassium inside the cell and reduce the amount of potassium in the plasma, leading to hyperkalemia. Apart from that, it has also been implicated in respiratory and asthma-related deaths and life-threatening conditions.